Swayam Prabha. Digital India. Educated India.
Hello and welcome to Gender and Society. This is lecture number 11, and in this lecture we will be talking about gender and health. So we will start with a couple of basic questions, that how is health understood, and what are the various consequences of gender's impact on health and healthcare, and vice versa. So here we will make an attempt to understand health as a sociological concept, and what are the various ways we can understand health as, and what are some of the important gendered aspects, some of the impacts of gender that we see on health across societies. So we will start with an understanding of how we understand health, and I will go with the World Health Organization's definition: a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. So what the WHO is proposing, and very rightly so, that to understand health we need to have this holistic idea that actually takes us beyond an understanding of disease, beyond the condition, the condition of the body of infirmity, or we need to keep in mind that there are these mental and social processes that constantly impact a person's health, and that actually gives a holistic idea of health of a person. So if you look at the sociology of health, you will come across an emerging idea, that the idea of healthy living, and this actually deals with the promotion of health at various geographic scales, local, regional, global levels, and we see the involvement of NGOs, of communities, of organizations such as the UN, the WHO, to actually promote this idea, this holistic idea of health globally and locally. So the idea of healthy living is one of the emerging concepts in the sociology of health. We also need to keep in mind that there are these public health policies in recent times, and we also need to consider what are some of the lifestyle choices that people make, some of the consumption patterns that people have, and some of the risks that people take in society that directly or indirectly influence their health condition, and that actually can be panned out on a gender spectrum. We also need to look at how the sociology of health examines socio-political critiques of health promotion, the impact of both morbidity on social life and social life on morbidity. So the relationship between how a person or a group of people chooses to have their social life, and the relationship of that with morbidity needs to be looked at. So we are talking about here is again an overall holistic understanding of health, which will bring into focus talking about family, talking about education, talking about religion, talking about economic standing of a person or a family or a group of people, and we need to examine health and healthcare with a gender lens, keeping these in mind. So to understand the WHO definition, we first have to understand that one of the earliest models to understand health of a person has been the biomedical model. So, what does the biomedical model say? It says that disease is an organic condition. It has non-organic factors associated with it, with the human mind, and it is considered unimportant and are ignored altogether. So, only pathological conditions are considered. So, the biomedical model really looks at disease as the organic condition and doesn't really bring in or examine the social cultural factors in the treatment of disease in the classic biomedical model. The classic biomedical model also talks about disease as a temporary organic state that can be eradicated, cured by medical intervention. So, if somebody has a disease, if there is a disease, it can be completely cured through medical intervention. Disease is experienced by a sick individual who then becomes the object of treatment. So, there is a whole deal of objectification going on here, that a person, the disease is the focus here, not the person, and it becomes an objective treatment. Disease is treated after the symptoms appear. The application of medicine is a reactive healing process. So, the classic biomedical model talks about that its role starts only once the disease is felt, once the disease is seen, once the disease is visible, and the application of the medical intervention, the medicine, is a reactive healing process to that disease that appears. And disease is treated in a medical environment, a surgery or a hospital, away from the site where the symptoms first appeared. So, the person who has the disease is transported to a medical environment where the person is treated. Oftentimes it's a hospital that the symptoms are examined and the disease is treated. So, this is in a nutshell how the classic biomedical model of understanding health looks like. But over time, what we have seen is that we have transitioned to the idea of the holistic model of health, as we see with the WHO definition, where we consider that apart from the the body, there are these emotional, spiritual, intellectual, occupational aspects in addition to the physical condition of the body that actually contributes to the health and well-being of a person. And more and more scholars are actually adopting this model, this holistic model, to understand the idea of health for a person. So, at this point, I want you to keep in mind that we had these classic biological model, and we have this emerging or now established model of the holistic model of health, which looks at the body with respect to the social, cultural, emotional, spiritual, all of those acting on the person. So, over time we have seen that there has been some contemporary transformations in conceptualizing health, given the definitional journeys that I just talked about. So, we see that we have transitioned as a society, or rather most societies have actually transitioned from an understanding of disease to an understanding of health. So, now we do not really talk about in terms of disease as much as we talk about health. So, now we have transitioned, or transitioning rather, to an idea that you always need a medical environment such as a hospital to we have transitioned to the idea of community. So, community living, community healthcare. So, we have transitioned to that idea. From acute to chronic, we have shifted our focus from cure to prevention. So, now we are more concerned in terms of health to prevent, not to be sick, not to fall sick. And unlike, previously where, a person can only be cured when, you see symptoms of a disease. From intervention to monitoring, and this is probably one of the most important transitions in healthcare practices that we see, that no longer are we waiting for something to happen, a disease or a bodily condition to happen, but we are constantly monitoring ourselves, our everyday lives. And this is one of the major areas where much of the emerging research on digital healthcare actually is happening, something that we will talk about in the next lecture. But this is a very, very important transition that is happening currently. We have transitioned from the idea of treatment to the idea of care. So, we again, again a preventive idea that you don't have to necessarily treat somebody after the person falls sick, but you can actually take care and probably prevent from falling sick. And also we have transitioned from the idea of the patient to the person, and this is the holistic journey, that it's no longer the objectified patient, but the person who is influenced, who has a bodily condition, probably a disease or symptoms of disease, and that person is as much influenced by the socio-cultural, economic, spiritual, psychological factors as with the anatomical conditions. So these are some of the key the conceptual transitions that we see in the study of healthcare. So where do we see gender coming in here? And gender has always been there at the discussion of health and healthcare, but here we want to use that lens a little more solidly to see how gender actually influences, or what has gender got to do with this. So one way of looking at the relationship between gender and health is to understand the transition from the homemaker breadwinner model. So remember in one of the previous lectures I talked about the homemaker breadwinner model, where we understood the separation of spheres, and women were the home was considered to be the women's sphere, and the outside world was considered to be the men's sphere, and the homemaker breadwinner model of informal and formal labor arrangements. So as societies have transitioned from that homemaker breadwinner model, the health conditions and the factors affecting health of a person has changed over time. So we need to keep in mind that this transition of that model actually goes a long way to have an influence on health. And also the theories that have been used to conceptualize gender, the emphasis actually lies on understanding the lived experiences of both women and men. So over time we have seen that these theoretical journeys to understand or to conceptualize gender actually has been to understand the lived experiences of both women and men in society. So here I want you to focus on the World Health Organization's gender policy, and this was put forward in 2002, where the WHO says society prescribes to women and men different roles in different social contexts. There are also differences in the opportunities and resources available to women and men, and in their ability to make decisions and exercise human rights, including those related to protecting health and seeking care in case of ill health. Gender roles and unequal gender relations interact with other social and economic variables, resulting in different and sometimes inequitable patterns of exposure to health risk, and in differential access to and utilization of health information, care and services. These differences in turn have clear impact on health outcomes. Evidence documenting the multiple connections between gender and health is rapidly growing. So, you see that in this view that the WHO puts forward, they have not only identified that men and women have different roles in society given different social contexts, but they have also identified that there is a difference in access and allocation of resources for women and men in any given society. So, and seeking health care or having access to health care is one such resource that is oftentimes not available to men and women equally or as required, and the WHO has actually pointed that out, that these differential access to resources or allotment of resources to men and women differently will have impact on health outcomes. So, they have also talked about the various research that's ongoing and that's emerging, that the connection between health and gender is actually cannot be ignored. It is actually there are multiple connections that we need to be mindful of. So, with that, we need to look at then what is the WHO's gender policy. So, they have a well crafted gender policy that the WHO will, as a matter of policy and good public health practice, integrate gender considerations in all facets of its work. So, they make it very, very loud and clear that it is a policy that matters, and it is a policy that will be integrated in all its facets of work. They also say that integration of gender considerations, that is gender mainstreaming, must become standard practice in all policies and programs. So, they point out very, very sharply, very, very boldly that gender mainstreaming is something that cannot be ignored. So, you have to bring in gender to the core. So, gender cannot remain on the periphery anymore, and it must become standard practice in all policies, in all programs for organizations and governments. And they further say that all programs will be expected to collect disaggregated data by sex, review and reflect on the gender aspects of their respective areas of work, and initiate work to develop content specific materials. So, they not only say, they not only point out the need of the hour, the need to actually mainstream gender in these conversations, in these discussions, but they actually provide a way to do that, a process to do that, that all programs will have to collect a particular type of data. They have to design their data collection in a way that all of these are reflected and analyzed in a particular manner, just to bring gender to the core of this conversation. So, just to give you an idea how the United Nations Millennium Development Goals look like in this respect, as you can see that they have 8 goals, and of which much of it is actually invested in understanding gender and health. For example, the first 2 talk about hunger and poverty, eradication of extreme hunger and poverty, achieving universal primary education. Goal 3, look at goal 3, they promote gender equality and empower women. So, goal 3 talks about directly talks about promoting gender equality. Goal 4 directly talks about reducing child mortality. Goal 5 directly talks about improving maternal health. Goal 6 directly talks about combating HIV, AIDS, malaria and other diseases. So, the United Nations also has, found that gender mainstreaming in this respect is, absolutely cannot be ignored, and this is not just ignored, but, it has to remain at the center of discussions and debates in this respect. So, now let's look at then what are some of the factors, some of the interconnected factors that determine an individual's health status. And some of these determinants actually include personal features, social status, culture, environment, educational attainment, health behaviors, childhood development, access to care and government policy. So, you see that there is this very complex network of several of these factors that actually influence, that actually determine a person's health status. And we have something called the social determinants of health, as you can see in the second point, that these points are also socially determined. Some of them are social constructs, and they are often socially determined, and so these are also noted as the social determinants of health. So now let's look at some of the what are some of the social determinants of health, or how does it pan out in the larger society. So one of the first points for us to start here is people judge their health in relation to others. So you will see, consider yourself, or consider somebody well, how often do you think that you're fine, or you're not feeling well, or your health status with respect to another person. And this actually is not just true on the individual scale, but it can also happen at a larger scale for a community with respect to another community, for a society with respect to another society. So this comparing your health in relation to others is a constant comparison that people do in society to understand how good or how bad they are in society. People often equate health with morality. So think of examples, think of events, think of situations which can affect a person's health, and it can be linked to ideas of morality. So people usually tend to follow a path where this morality is not questioned. So they will not indulge in behavior or not do certain health related activities when morality is questioned, and so people often actually equate health with morality. The third point here is cultural standards of health change over time. So what it meant, for example, to be eating healthy, 10 years back or 20 years back in a given society may shift over time to an understanding of eating, healthy in a current time and space. So the cultural standards of health actually change over time. The fourth factor is health and living standards are interrelated. So if your living standards are reasonable, are fairly good, then your health is expected to be good. But if your living standards are not up to the mark or not that well, then it will have, or it may have, an impact on the health issues. And finally, health relates to social inequality. So how healthy you are is also defined or also decided by your position in society, and which social rank or which social order, which the social location, social position are you occupying in society. So health in society can be judged, can be understood by looking at these several factors. Here you see some of the key determinants of health from the Public Health Agency of Canada, and actually you can see that some of the policies and interventions on health actually relate to various scales, and starting with the individual scale, where you have the genetic makeup, the sex of the body, age of the person, and it goes to scaling up to governance policies, and including the physical environment, including water, sanitation and pollution. So and you see, and these scales actually go all the way from the individual to the local to the government to the environment, social environment, and you see the socio environmental factors, the socioeconomic status, education, social capital, culture, gender norms. So all of that actually in a very holistic manner determine the health of a person, and several of these policies and interventions are designed, are crafted around this holistic understanding. So if we take a look at the 2015 Millennium Development Goal report, then we will see that since the 1990, the number of people living in extreme poverty has declined by more than half. And this is this Millennium Development Goal report actually says that this has been a quite significant progress from historical trends. The proportion of undernourished people in the developing regions has fallen by almost half. The primary school enrollment rate in the developing regions has reached 91%. Many more girls are now in school compared to 15 years ago. Remarkable gains have been made in the fight against HIV, AIDS, malaria and tuberculosis. The under 5 mortality rate has declined by more than half, and maternal mortality is down 45% worldwide. The target of halving the population, the proportion of population who lacked access to improved sources of water was also met. So you see that the journey that the policies had was to address some of these very important gender related health issues, such as maternal mortality, such as HIV AIDS, such as girls enrollment in schools, which is a huge health issue, so they have actually paid attention to some of these very central problems, very central issues that that had been plaguing societies and need to be addressed. So, at this point we need to clarify two concepts with regard to gender and health care. So, what do we understand by equality versus equity? So, just to clarify, gender equality, as you can see on the screen, means the absence of discrimination on the basis of a person's sex in opportunities, in the allocation of resources or benefits, or in access to services. So, complete absence of discrimination on the basis of any of these attributes. Gender equity, on the other hand, means fairness and justice in the distribution of benefits and responsibilities between women and men, and often requires women specific projects and programs to end existing inequities. So, just to clarify that equality and equity, they are conceptually different, and then when we talk of gender equity, particularly in terms of health and healthcare projects, we see that there is a requirement of more women specific projects and programs to actually end the existing inequities. This is one conceptual clarification I want you to have in order to have an understanding of health and gender. So now the question is, whose health are we talking about? And again, I bring in an understanding of the intersectionality approach, the model of intersectionality here, and we have seen that changes in the locus of care and burden of responsibility for health actually is affected. The genetics, informatics, imaging and integrated nanotechnology are redefining our understanding of the body, health and disease. So we see technology, as we will see in the next lecture, has very, very important role to play for us. Remember earlier this lecture I talked about monitoring. So we are constantly monitoring ourselves through these gadgets, through these apps, and that has redefined our understanding of the body, of health, of disease. And health is no longer simply the domain of conventional medicine nor the clinic. So as of the the journey from the biomedical model to the holistic model, health no longer actually talks about conventional medicine only, neither does it only talk about the clinic where somebody can be treated to good health, but it actually talks about a much broader understanding than that. So let's now look at some of the gendered consequences, some of the influences, the direct impacts that gender can have on women and men's life with regard to health. So when we talk of women and life stages, we fairly see these life stages into 4 or 5 stages, and starting with the conception to adolescence, we see that there are certain practices, there are some processes, there are some social patterns, assumptions that are at play in societies that directly affect women and health. So the impact of sex selective abortion, inadequate health care, poor nutrition and child marriages. So these are some of the very, very important patterns, practices that we see that actually has a huge negative influence on women at an early stage, right from conception to the adolescence phase. In the adolescence phase, we see that women tend to girls tend to get affected by youth pregnancy. So if somebody becomes pregnant very, very young, or the sexually transmitted diseases or infectious diseases. So that's a health problem we see in the adolescence stage for young women or girls. For the childbearing years, we have this grave issue of maternal mortality and morbidity, and that has continued to be acute in certain parts of the world as I talk. And the middle years of a woman's life, which is usually a neglected period, which is sandwiched somewhere between the youth and the old age, that when the woman has actually passed through the previous 2 or 3 stages, the middle years tend to be neglected for in a woman's life, and it is very sandwiched between the youth and the old age in a somewhat ignored manner. And finally, the old age, one of the growing challenges in the old age is that older women are facing, who are living longer but not always better. So the assurance to live longer with a good health is the picture is looking very grim. So as you can see on the screen that these are the 5 stages of life that a woman passes through, and at each stage you see that there are these health factors, these processes that directly influence the health condition of a woman. So I was talking about maternal mortality, and just to give you some figures here, in Africa you see a figure of 830 deaths per 100,000 births, and the lifetime risk of maternal death is 1 in 16. So it's actually very, very high that a woman giving birth may face maternal death. So compared to the wealthy countries, where it's an average of 24 deaths per 100,000 births, and you have a lifetime risk of maternal death 1 in 2,800. So you see the difference in figures. In Africa it's 1 in 16, and for the wealthy countries you have 1 in 2,800. So it's a huge difference in figure, both in terms of number of deaths per births per 100,000 births and lifetime risk for maternal death. And it is seen that women in Africa are 175 times more likely to die than women in North America or Europe. So you see the comparison, the figures, that the probability to die is so much higher in certain parts of the world than compared to some others. Now, infertility is such an acute problem in Africa that they have a belt, a geographical belt, as you can see on the screen, that is called the infertility belt. And this infertility belt is in certain countries in Central Africa, as you can see, where the infertility rates are as high as 30%, as the chart shows. And the reasons for this are not clear, but scholars propose, and organizations who have studied these societies, they propose malnutrition and high rates of sexually transmitted infections are probable factors. So this is such an acute problem, acute health condition in certain parts of the world, that there are social consequences, there are gender consequences because of that. So now, since we are talking about maternal mortality and then we're talking about infertility, let's look at how research on biological conditions have actually progressed. Now let's look at another grave issue around gender and health, and in terms of violence against women. So from various studies, it is seen that the percentage of total murders committed by the opposite sex intimate partners, as you can see on the chart, on the bar graph, that the percentage of all murders of men are really low compared to the percentage of all murders of women. So the increased risk of interpersonal violence or spousal abuse and sexual abuse in an intimate relation is a constant factor in terms of health and gender that we need to keep in mind, that we need to study, and that we need to understand that why something such as that happens over a given time and space. So why is that a risk of violence that we see constantly, not just at society at large, but also within intimate relations, such as examples include spousal abuse. And in a multi-country study, it was shown that 23% to 49% of women have been physically abused by an intimate partner. So this is a global pattern, it's a global a process that we see, and it shows that just how the idea of gender, idea of understanding what gender is, can have grave consequences, can have absolutely negative consequences, even for intimate relations such as marriage or in the family. So this is another area that we need to be mindful of when we talk about gender in terms of health and health care. The other area that we need to look at is so how have the understanding of men's health evolved over time. So this will require us to recall some of the ways where we have described masculinities, we have understood masculinities, and how have such masculinities been related to health. So that understanding of the various ways masculinity is negotiated. How is gender constructed and embedded in social, economic and political contexts and institutions? So gender, as we now well know, that is constructed and embedded, but that how is a work in progress, and it evolves. So we need to understand exactly how are these gender relations, such as the negotiations of masculinity, negotiations of femininity, are actually embedded in these social structures. How culture and subcultures influence how men develop their masculinities and how they respond to health issues. So we have with us or we bring with us these cultural understandings of how we define men, how we define women in society, and with an understanding we also define masculinities and how those understanding actually respond to health issues. So for men's health and masculinity, we need to have a much broader conceptualization of health behaviors and lifestyle choices, understanding lifestyle choices, just as we need to understand women's health in terms of femininity and the repercussions of that. So the idea of gender socialization, the idea of how we grow up into being women or men, or how we learn our various social roles in society actually influence these dynamics. There are certain masculine ideologies that construct the idea of being a man in society, and these masculine ideologies go a long way in a very important way to define a person's health condition in society. And to understand all of that, to understand in a holistic manner that which men's health are we talking about, we need to adopt an intersectional approach. We need to ask questions that which men are we talking about, and we need to identify the various axes of differences that we talked about in previous lectures, and we need to adopt that intersectional approach to understand the full story, or at least part of that story. So we see that from existing studies, what emerged is that masculinity is an important influence on health behaviors, especially for men, although research on masculinity and women's health remains very sparse. So it's a field that needs a lot more attention that it has gained, and particularly with emerging ideas of the role of technology, the role of digital healthcare, the role of how we are redefining ourselves, understanding of health. This is an area that will be emerging, and it needs a lot more attention to be studied. But then at this point we need to be very clear that the constructions of masculinity actually influences the health behavior of a person. The health behaviors relating to diet, alcohol consumption, physical activity and smoking have been examined as modifiable determinants of health status, and this was proposed in a study in 2011, and sex differences have been noted for these health behaviors. So again, going back to lifestyle choices, going back to lifestyle habits, such as what sort of food do you eat, what sort of diet do you follow, consumption of drugs and alcohol, physical activity, smoking. So these are all attributes that go a long way to determine the gender identity of a person, and this has been put forward in a study to show that these are very important indicators that influence health behaviors. The idea that help seeking and emotional expression are coded as feminine, and so many men prefer more action oriented coping styles. This was proposed by Davis in 2000, which can include worse health behaviors such as alcohol consumption. So what happens is, because society presumably labels certain types of health behaviors, such as if you seek if you seek help, or if you emotionally want to express yourself, and these are coded to be feminine attributes, men who want to subscribe to ideas of masculinity prefer to go a different route, and they prefer to go a more action oriented coping style, and oftentimes those coping styles actually take them to negative paths. And so it goes back, the whole discussion actually goes back to the idea of the social constructions of masculinity and femininity. So now we are faced with a question that how does the male gender preference affect the health of women? So we have seen that several studies have been done to actually find out that what are the social impacts, what are the social connotations of male gender preference in societies, as we well know of, affect the health of women. So we have seen that these studies propose that couples unable to control family composition tend to have higher numbers of children as they continue trying to have a male child, and this is a quite common phenomena where families are unable to control the family size, they don't have a male child at first, they continue to have children until the time they have a male child. So this is one of the major reasons that with respect to gender and family size, that we see the cultural preference of a male child being privileged over a female child. We see that large families in low income countries, girls are less likely to receive health care, hospital care, and adequate nutrition. So if you have very large families, or if you have a lot of children, and your income doesn't support a standard livelihood, then chances are, and it's quite a given, the chances are that one of or a few of the children will be neglected, and oftentimes what is seen is that the preference goes to the male child or male children in the family, and girls are less likely to receive health care or hospital care, or even adequate basic nutrition. So this is put forward by a lot of studies. We do see that in industrialized countries, mortality among female children is 20% lower than male children, while in some countries such as China, where small family sizes are mandated, mortality among girls is 33% higher than boys. So we see that in countries which do not have a mandate of small family size, or in industrialized countries, that mortality among female children is 20% lower than male children. And countries such as China, which had a small family policy until a few years back, mortality among girls is seen that it's 33% higher than boys. So you see that directly how cultural preferences, government policies, social constructions, social norms, beliefs actually go a long way, you know, and you're seeing that all these examples that they pan out to give us, you know, these various gender dynamics in society, and here with respect to health. So now, so the question is, if gender inequalities give rise to inequities between men and women in health status. So, you know, we talked about inequality and inequity, and you know, we will consider here, let's look at a few examples, hypothetical cases, and see, you know, what is one of the, or a couple of the repercussions that societies which have you know, gender inequality have on inequity between men and women in terms of health status. So we see that there is a tendency not to provide minimum health care to women because norms in her community may prevent her from traveling alone to a clinic. So, you know, there are countless examples such as this. This is a hypothetical case I'm using, but there are countless cases where you know, when women need basic healthcare attention, the minimum healthcare is denied just because you know, she has to travel, she has to commute to the clinic, and there is no one there to accompany her, and therefore, you know, it is just let go. So something very basic as minimum healthcare is not provided, is not you know, accessed in this case. We see that the social construction of masculinity puts young men or boys typically do high risk activities to prove their masculinity. So imagine, you know, somebody, you know, that you know, maybe a young man or a young you know, a boy who has this idea of you know, what it means to be masculine, what it means to be a man, and engages in this high risk activities that may be threatening for health. So just imagine if you know, those ideas, those signifying factors, those signifiers around masculinity did not exist in society, would the person still engage in that, you know, high risk activity, is the question to ask here. For example, smoking as a masculine habit reflects in mortality rates due to lung cancer for men greater than women, as it often marks a masculine behavior. So you see that lifestyle you know, habits such as smoking is attributed to as you know, a masculine habit, and therefore you have the rates, the mortality rates due to lung cancer much higher for you know, men than women, because you know, one of the major reasons being that this lifestyle you know, habit is a marker of masculine behavior. So as you can see that these are, you know, hypothetical cases, but they can actually translate, and they, you know, often do translate to reality, you know, giving rise to these various you know, patterns of health and health practices in terms of gender. So if we look at you know, South Asia, and this is a study done by Fikri and Pasha in 2004. This actually, you know, goes hand in hand with what Amartya Sen in 1990 talked about, and then what Ravinder Kaur and others have talked about recently, is that the life advantage for girls and women in South Asia are quite grim, and they actually, you know, talk about you know, the negative consequences. So the gender discrimination at each stage of the female life cycle, health disparities, sex selective abortions, neglect of girl children, reproductive mortality, and poor access to health care for girls and women. So you know, all of these are, you know, practices that directly you know, impact the life advantage of girls and women in South Asia. So it is not just, you know, a gender discrimination at some level, it is also the violation of fundamental human rights as we understand it, and so they actually point out that policymakers, program managers, health professionals and human rights workers in South Asia need to address health effects that gender plays out through the life cycle, and organizations and policy workers and governments have taken up this role very seriously since the last few years, where again the gender mainstreaming is now not an option, it's a requirement. So as you can see that it is not just in terms of gender discrimination, but it also puts in questions of violation of fundamental human rights. So I want to conclude here with directing you to a couple of online resources that I want you to take a look. So if you go search for global burden of disease, it will take you to an interactive website where you will be able to see what sort of health patterns are there globally, and it's a very nice interactive platform for you to look up how many of these health conditions pan out in terms of gender. And then I also want you to go take a look on the documentary, which is a PBS documentary. It's called Sick Around the World, and it shows that the healthcare practices, the healthcare systems, policies in 5 capitalist countries of the world. So it will just give you a very good idea of what sort of healthcare practices are carried on in the capitalist nations, and a very nice comparative idea globally. So to sum up, we have seen that the inequalities in access to healthcare present the single largest barrier to the health of women. So when we talk of the access and the access to healthcare and allocation of healthcare resources, it is a quite significant barrier for women. Across the world, women are less likely to have health insurance or to be able to afford care when they are ill. So this continues to be a problem where women are less likely to have access to health insurance, or they would be in a position to pay for a resource, for a healthcare resource. Where biological sex differences interact with social determinants to define different needs for women and men in health, gender equity will require different treatment for women and men that is sensitive to these needs, which is that as long as we will continue to think about gender in terms of biological sex differences, then the idea of achieving a fair and just way for health for all will require different treatment of women and men that is sensitive to these needs. So it needs a completely different understanding, a completely understanding that is is on a more holistic level. Social factors of discrimination should be considered for different and inequitable health outcomes, which is something that we have talked about in this lecture, that we cannot ignore social factors that go a long way towards discrimination on the basis of gender. And health equity will require policies that encourage equal outcomes, including differential treatment, to overcome historical discrimination, which means that we need to think of policies at the local, regional, global levels, which will encourage these equal outcomes. And we need to overcome historically what has been discriminatory practices, what has been violation of basic human rights, to actually achieve health equity for all. So I want to conclude here with a question in mind for you, that what have been some of the recent trends in health development with respect to gender in India and globally. So you can look up a few journal articles, a few readings if you want to read Emily Martin's The Woman in the Body which is a cultural analysis of reproduction, or you can read up Leon Goris's epidemiology. So look up these couple of readings, and also look up a few journal articles if you can, and see what has been some of the recent trends in health development with respect to gender in India. And in the next lecture we will continue talking about healthcare practices, particularly focusing on technology and gender. Thank you.